A6 anesthesia. Fasting guidelines. Fasting guidelines prior to surgery, Canadian Anesthesiologists Society. Before elective procedures, the minimum duration of fasting should be 8 hours after a large meal of solids that includes meat, fried, or fatty foods. 6 hours after a light meal, e.g., toast or crackers, or after ingestion of infant formula, non-human expressed breast milk fortified with additions. 4 hours after ingestion of breast milk. 2 hours after clear fluid intake, including water, pulp-free juice, complex carbohydrate beverages, and tea or coffee without milk, for adults. 1 hour after clear fluid intake for infants and children. Hematological disorders. History of congenital or acquired conditions, sickle cell anemia, factor V deficiency, IP, liver disease. Evaluate hemoglobin, hematocrit and coagulation profiles when indicated, see Table 1, A4. Anemia. Preoperative treatments to increase hemoglobin, PO or 4-iron supplementation, erythropoietin or pre-admission blood collection in certain populations. Coagulopathies. Discontinue or modify anticoagulation therapies, warfarin, clopidogrel, ASA, apixaban, dabigatran, in advance of elective surgeries. Administration of reversal agents if necessary, vitamin K, FFP, prothrombin complex concentrate, recombinant activated factor V. Endocrine disorders. DM. Clarify type 1 versus type 2. Clarify treatment, oral antihyperglycemics and/or insulin. Assess glucose control with history and HbA1c. Well-controlled diabetics have more stable glucose levels intraoperatively. End organ damage. Be aware of damage to cardiovascular, renal, and central, peripheral, and autonomic nervous systems. Preoperative guidelines for DM. Verify target blood glucose concentration with frequent glucose monitoring, less than 10 megamoles/L in critical patients, less than 7.8 megamoles/L in stable patients. Use insulin therapy to maintain glycemic goals. Hold biguanides, aglycosidase inhibitors, thiazolidinedionase, sulfonylureas and GLP-1 agonists on the morning of surgery. Consider canceling non-emergency procedures if patient presents with metabolic abnormalities, TCA, HHS, etc., or glucose reading above 22.2 to 27.7 megamoles/L. Formulate intraoperative glucose management plan based on type 1 versus 2, glucose control, and the extent of end organ damage. Hyperthyroidism can experience sudden release of thyroid hormone, thyroid storm, if not treated or well controlled preoperatively. Treatment, beta blockers and preoperative prophylaxis. Adrenocortical insufficiency, e.g. Addison's, exogenous steroid use. Consider intraoperative steroid supplementation. Obesity and obstructive sleep apnea. Assess for comorbid conditions in obese patient, independent risk factor for CVD, DM, OSA, cholelithiasis, HTN. Previously undiagnosed conditions may require additional testing to characterize severity. Severity of OSA may be determined from sleep studies and prescribed pressure settings of home CPAP device. Both obesity and OSA independently increase risk of difficult ventilation, intubation and postoperative respiratory complications. Interventions for preoperative smoking cessation. Cochrane DB-SYST Rev 2014. 3. CD002294 Purpose: assess the effect of preoperative smoking intervention on smoking cessation at the time of surgery and 12 Mo postoperatively, and on the incidence of postoperative complications. Methods: systematic review including RCTs that recruited people who smoked prior to surgery, offered a smoking cessation intervention, and measured preoperative and long-term abstinence from smoking or the incidence of postoperative complications or both. Results: 13 trials enrolling 2010 participants included. Overall quality of evidence was moderate. Compared studies involving intensive intervention, which included multi-session face-to-face counseling or computer-based scheduled interventions, versus brief interventions. These were pooled separately. An effect on cessation at the time of surgery was apparent in both subgroups, but the effect was larger for intensive intervention. For long-term cessation, only the intensive intervention showed effect. In those that had intensive intervention, there was significant effect in preventing any postoperative complications. Conclusion: there is evidence that preoperative smoking interventions providing behavioral support and offering NRT increase short-term smoking cessation and may reduce postoperative morbidity. Interventions that begin 4 to 8 WK before surgery, include weekly counseling, and use NRT are more likely to have an impact on complications and on long-term smoking cessation. Preoperative anemia and postoperative outcomes in non-cardiac surgery, a retrospective cohort study, Lancet 2011. 378, 1396-1407. Purpose: assess effect of preoperative anemia on 30D postoperative morbidity and mortality in patients undergoing major non-cardiac surgery. Methods: patients undergoing major non-cardiac surgery in 2008 from the American College of Surgeons National Surgical Quality Improvement Program database. Results: 227,425 adult patients. Postoperative mortality at 30D was higher in patients with anemia than those without, or 1.42, 95% C 1.31 to 1.54. Conclusion: preoperative anemia, even to a mild degree, is independently associated with an increased risk of 30D morbidity and mortality. Pre-anesthetic checklist. Ms. Maids. Machine: connected, pressures OK, all meters functioning, vaporizers full. Suction: connected and working. Monitor: all monitors appropriate for the case. Airway: laryngoscope and blades, syringe, stylet, oral and nasal airways, tape, bag, and mask. 4. Second 4 setup and ready if needed. Drugs: case-specific drugs ready and emergency medications in correct location and accessible. Special equipment: OG tube, CVP monitor, shoulder roll, etc. A6